Hi everybody, my name is Sebastian Parratte and it's my great pleasure to be with you here tonight in Madrid. We are live and I have with me Dr. Ganapathi, Dr. Adolf Lombardi from the US, and we're going to talk about personalized alignment. What a program. So first and foremost, I want you guys to please introduce yourself, describe your practice, and then we're going to discuss about the real topic.
So I'm an orthopedic consultant working in North Wales in UK. My practice is mainly hip and knee replacement. I've been using PSI knee for since 2012, then gone into personalized knee replacement for the past 3 years. Now I'm using the ROSA robot for the past year.
My name is Adolf Lombardi. I'm an orthopedic surgeon practicing in the US. I've been in Columbus, Ohio. This July marked 35 years. I do the Lombardi alignment, and we'll get into that shortly.
Fantastic, I love that, because at the end it's personalized as well. It's very interesting. So let's go back to the basic. Muthu, you're doing personalized alignments.
Yes.
Adolf, you're doing the Lombardi personalized alignment. So can you describe a little bit your philosophy? And we're going to start with the Lombardi alignment, because we are very excited to hear about that.
Well, today we heard a lot about kinematic, restricted kinematic, inverse kinematic, functional alignment, anatomical alignment, and mechanical access. So, when I started practice in 1987, there weren't the sophisticated instrumentation that we have today, and they were just slowly being developed. I think instruments, just like the technology side of it, has advanced. And so we have a lot of new instruments that really help us get the components in the position we desire. So what do I desire? My goal is to take off that amount of bone that I'm putting back with metal. Now, it's not exactly that, because as we'll hear, I may be taking a little bit more off medial than I do laterally in order to obtain my mechanical alignment. But I'm going for restoring the joint line. And I look not only at the femoral joint line, I also look at the tibial joint line. I find that when my fellows start, they make these very skimpy cuts, and they're elevating the tibia, and then they're struggling to get even a 10 millimeter polyethylene in, because they just haven't taken the correct amount of bone off the tibia. Now, my tibial cut is the classic tibial cut, where I'm taking a little more off laterally than I am medially, and in flexion, I'm doing the same thing there, taking the difference in medial lateral cuts. But I believe in creating that envelope and then balancing the ligaments around that envelope. Now, that means you have to have a knack or a sense of what is balance, how tight is tight, I guess. And so I do want a very tight medial side, and will accept a little bit of laxity on the lateral side. So the first thing I do when I do a knee replacement, patient's under anesthesia, I examine that knee. I've examined them in the office, but now they're fully relaxed, and I just see how much lateral laxity, because most of what we're dealing with is varus, right?
Yeah.
And a lot of this alignment has to do with varus. I don't think it has to do with valgus.
Correct.
Correct me if I'm wrong, but I think if you take a valgus knee and you keep them in valgus, the patient's usually not that happy. So I would get them straight, whatever that means. So that tells me just how much gap I have laterally, because a lot of these varus knees have a little more. And then I can determine whether I'm going to take my standard distal cut, or maybe take two less, because they open a lot laterally. And once I make all the cuts, then I put the polyethylene in, and I balance the knee around that, which means I've adopted the Johan Bellerman's and Jan Victor technique of doing some pie crusting on the medial side if I need to. And I've learned to release that posterior lateral corner in the valgus knee as necessary. Now, I would tell you that having done that, I'm doing less and less of the PS type knees. I'm doing more CRs. I will do a smattering of the ultracongruent or MCs in particular cases that I feel I need that added stability, because the PCL, quite frankly, is not great. And I've been in practice for 35 years, so what am I seeing now? I'm seeing my patients return at 20 years with polyethylene wear, but the metal is well fixed, and I'm doing liner changes. Now, that's in my I would say standard BMI patients, but as you may know or not know, I'm called the heavy person's doctor in my neighborhood. So I do a lot of patients with BMIs in excess of 50, and their polyethylene doesn't last as long.
Yep.
So I'm worried. I can change it. I'm concerned. I won't say worried. I'm concerned that how much tibial varus can we accept in this personalized alignment?
Thank you so much, Adolf. It's a very good introduction for you, Muthu, because we've heard about the Lombardi personalized technique. Now we want to look at the personalized alignment, as we can describe here. And please give us your advice and your technique, and we're going to answer about this tibial alignments, and for particularly for specific cases, and how far can we go?
Now, as Adolfo explained, he's doing some sort of personalization. Maybe your personalization, what I'm trying to do is like personalization in regards to the patient's knee. So as I told you, I came and saw you doing the signature knee, I think 2011. Then I've been doing mechanical alignment for a number of years. And you can see what we are doing is changing the anatomy of the patient by our dogma about a neutral tibial cut. I agree we cannot go too much varus or valgus. That's the reason when we started, there was a, the shape match was all, pure kinematic was there. I wasn't happy and I did mechanical alignment. So about 3 years ago, Dr. Wendy Tolley, my mentor in Montreal, he introduced the concept of restricted kinematic alignment. So basically, we are still within about few degrees of varus. We're not going extreme. So the way I look at it is when arthritis, what is arthritis? Is lots of cartilage and maybe sometimes bone and sometimes soft tissue deformity. So if you're treating, it's like, something you want to resurface this femur and the tibia. If you do that, and if you're within our limits, then most of the time, the soft tissues accommodate it, and you can create a physiological soft tissue balance for that particular knee. For example, in females, it's a bit more lax. In men, it's a bit more harder. So if we resurface the joint within our limits, that again is variable. So I said 4-degree varus, but usually I'm keeping it only at 3 degrees of tibial varus. And we know that in single stance, even if there is slight varus in the tibia, actually it's neutral position. And all these studies, I think Seb has done a study where he found that it didn't make a difference. I think the problem is when you plan an unbalanced varus, it's unintentional and you're loading it in a varus position. But here, because the femur is in valgus as well, you got a bit of obliquity. I think it's probably okay. But as you know, in Stephen Hall's his published results, at 10 years, like 98% survival, despite a lot of outliers. I'm too scared to go along that line, so it's my first transition step. And to do that, I need new technology. That's the reason I'm more confident with the robot, because then I can do within half a degree or 1 degree.
Adolf, in the US, Hungerford came up with this concept already a few years ago. I think it was like 40 years ago, about the preserving some valgus in the femur and preserving some varus in the tibia.
The PCA, the porous coated anatomical knee, which was sold by Helmetica, the designers were Hungerford, Krakow, and Kenna. And the philosophy was cut the tibia in varus, so that exactly what you said, so during gait, be parallel to the floor, and then cut the tibia, femur, in a little more valgus. The problem that many surgeons ran into, which is what you just pointed out, is that the human eye cannot tell what 3 degrees of varus is. Yes. The human eye has a better concept of what 90 degree is. Exactly. And so if you aim for 3, you're in my comfort zone. Okay, so when my post-op X-ray comes up and it's about 2 or 3 degrees of varus, I just tell the fellows we did kinematic alignment.
Exactly.
Yes.
So, but if you aim for 3 and you get 5 or 7, now we have a problem. So I wholeheartedly agree with you. If you're out there and you're deciding you are going to accept some tibia varus, you need some augmented technology, some added technology to help you do that. And you've adopted the robot, and I think that's fantastic.
Yep.
And that's where I would say, people say, well, you never use a robot. Well, I do use a robot. I have cases where there's hardware in place or a big deformity, and I feel that gives me an added advantage. And I might be, in that case, tweaking a little bit of varus on that tibia or whatever. But I want to know where it's at.
Yeah.
And I feel the confidence with the robot to tell me that, because I know my eye can't tell me that.
It's a very important point, because if you shift the curve, like you said, on the dangerous zone, that's where and when our patient are going to have problems. So this is very dangerous. So to compensate for this inaccuracy in our eyes and in our hands, we need assisted technologies. So Muthu, you have an experience on PSI and then robotics. Yes. Can you briefly speak about that? And Adolf, I know that you have a huge experience on PSI as well, and now robotics. And I want to have your feelings about that, because you have seen all this new technology coming up. You have tried all of them, and you have this also huge background in knee arthroplasty. So your view on that, please. So Muthu, start with your view.
With the PSI, I know I was doing the Zimmer next-gen thing. With the software, actually, it resurfaces the femoral condyle. Even when you rotate it, the external rotation was based on the posteromedial femoral condyle, which was sort of, nobody thought about it, but that's what they're doing. So you maintain the posteromedial offset regardless of external rotation. Then when you cut the tibia into neutral position, you end up doing more soft tissue releases, which obviously that happens. Now, when I moved to this technology, because of the cartilage mapping, I can actually appreciate what is the cartilage loss in the 3D model, and then I can plan accordingly. But one of the problems, which I told in the symposium, was that you cannot analyze how much was the bone loss, and the soft tissue laxity you can assess with the PSI. That's where I think the robot helps me, because I can analyze everything, and then everything, I will have a basic hierarchy of what I will accept or accommodate. So the medial femoral condyle, I want to resurface so that we can create easily the medial collateral isometry. Everything else, I'm happy to compromise a little bit to accept within the parameters. That's the way I look at it, and that makes life so easy. I don't think you need a CT, because other problem with the CT is that it can, if there's bone loss, it will increase the distal femoral angle or increase the varus. And a lot of all these, the CPAC classification, where there are extreme cases, I think they're all CT based, because then you can look at as if 9-degree valgus, but it could be that there's just bone loss. And the patient, if you ask them, they say the knees were straight. So when you compensate for the bone loss and actually the cartilage loss, you don't need to put in too much valgus. It may be only 3 or 4-degree valgus. So most of the patients, I think they fall, particularly in the Caucasian group, I think they fall within a very narrow bell curve compared to, say, for example, the Asian population, where there's much more varus. That's what I feel when you look at the cartilage and bone, rather than just looking at CT.
So the huge interest of the robot to reach the target that you define preoperatively or intraoperatively based on the ligament balance as well. Yes. Adolf, your view on the evolution of these technologies? What is how can we summarize this evolution, and give us a little bit your feelings about where we go or where we should go, because it's very important for us.
So I started off, as I said, using all the mechanical instruments. Then computer navigation came along, and I tried a little of it, and I didn't feel it was adding a lot more to what I was doing except time to my OR.
Yep.
And so when the patient-specific guides came along, yes, I thought, well, here, I can preoperatively plan what I want to do. And I think probably one of the unrecognized beauties of that is that you could do what Steve Howe was telling you to do if you wanted, because you could set all your own defaults, or you could set the defaults to get mechanical alignment.
Yes.
And I did a number of those. They worked very well. They were giving me what I was getting with my instruments, and I was actually a little better, or a little more precise. But as you said, it didn't tell me anything about soft tissue, but neither does the way I do it until now, where I'm judging just how much I want to take off of femur and tibia. I think that's where my personalization comes in. Where I see the robot adding the other feature is that you can, and I think this is what our young colleagues love, is they can go ahead and look at the patient's knee, dial in how they want to cut the distal femur, how they want to cut the proximal tibia, whether they're putting in the 2 or 3 degrees of varus, less valgus, and then they can take that model through a range of motion and decide that they're going to get their gaps pretty balanced, medial and lateral. And I think that's the strength of doing a robotic knee, determining before you make the cuts what you're going to ultimately get. And then you can tweak it, whether you're going to say, okay, I might be more of a soft tissue releaser. Other guys might say, well, I'm going to take another degree of varus. And so when I do the robotic knee, I do play around with that, and I will go a little bit outside of my comfort zone, if you will. But I've also learned now that, I put a knee through the range of motion, and it's squeaky tight on the medial side. Am I going to poke the medial collateral, or, what I learned from Martin Roche, take the saw and cut a little bit on that. Now, I don't have the robot to tell me to do that, but got my Lombardi navigation, ocular navigation going, and I'll get there and I'll take a little off that medial side, put the things back in, and now I've balanced the knee without doing more than probably taking off the deep medial collateral ligament, just taking off the osteophytes. And when I can do that, I'm very happy to do that.
Yeah, just remind us, how many knees did you do in your career to do that, to be able to do that properly? And because we don't want our young colleague particularly to go back on Monday and say, oh, yeah, Dr. Lombardi said that in this show.
I've been in practice
Zimmer Biomet.
35 years, and I've done 35,000 total joints.
Okay, just a reminder, guys, okay? Because it's not in the hand and the brain of anybody. So
it's like Michelangelo doing 35,000 Davids. But we are all not Michelangelo. No. So we need some aids.
Yeah. No, and I agree. I think that is where I would say, our younger colleagues are, the fellows that are coming to interview with me, the fellows that I'm training, they want to learn the robotic techniques, and I think it really has to do with getting that 3D perception. Where's that knee going to be, and then executing the plan. Yeah. And I think that's the beauty of the robot, which you don't get with a lot of the other technologies. I think the future is going to be even more robots, and I ultimately believe this: the robots have to become agnostic, prosthetic agnostic. We can't have a hospital that has an X, Y, Z robot to do 3 different implants. Why can't it be agnostic? Why can't it be the robot to put in total knees?
Let's call the four CEOs of the 4 major orthopedic companies, and let's ask them the question. Yeah, but it's it's true, because now it's a tool. It's a tool, and we are using it on a daily practice. Yeah. Like you said, it's made for one prosthesis today, but maybe one day we can change that.
So it sits in the corner of my hospital. If no one's doing component Y, it sits there for the whole week.
True.
Until that person comes in next week.
These machines are very cheap, so it's not a big deal.
Yeah.
So it's
it holds my lead too very easily.
Muthu, any comments?
Yeah, one of the things I think the problem with the robotic is people are worried about numbers if you're not used to it.
Right.
If you didn't do navigation or PSI, there's so many numbers, and obviously it's a bit difficult because you're not used to numbers. What I think is, in the future, when we are all a bit more experienced and the results come, we all have some sort of alignment goal. What is each one? What do you want to compromise? And I expect there'll be machine learning and AI to be used for each particular surgeon. So once you put the reference points and give the soft tissue balance, the AI will tell you what's the most appropriate position with all the parameters, and then you can tweak it if you want, but make life so easy.
Yeah, the number are sometimes a little bit confusing, because there's more than 1 million of combination. So this is probably a way of going for the future.
But guys, we need one more piece.
Yes.
We need to understand better than just taking the knee through the range of motion. What is the tension in these ligaments?
That's true. That's true.
The robot has to be combined with some sort of tensor information guide that tells us. And then I love what you just said, because I do think that's going to happen, where you're going to take the knee through a range of motion and it's going to spit out, this is the best combination for this patient.
Because maybe
because we're going to teach it that.
Exactly, and maybe we can understand better what we're doing on a daily basis. So guys, I would like to really thank you for this debate. It was very interesting, very constructive, which is not always easy on this particular hot topic. And I hope that you guys learned a lot, and we are always very happy to keep on trying to educate on this topic. Thank you very much for watching.
Thank you very much.
Take care, and don't go crazy on Monday, please.
Thank you.